Okay, so hello everyone. My name is Ben Adam. I'm a renal pathologist at the University of Alberta Hospital in Edmonton, Canada. And on behalf of the Renal Pathology Society, it is my great honor to welcome you to today's session. So for those of you that don't know, the Renal Pathology Society is a nonprofit organization committed to the improvement and dissemination of knowledge regarding the pathology and pathophysiology of renal disease. The RPS promotes excellence in diagnosis, fosters basic clinical and translational research, encourages training and education in renal disease, and sponsors US-based and international conferences and symposia. We also bring news and updates pertaining to renal pathology to our members around the world. So today's session is the first in a new RPS webinar series focused on the pathology, genetics, and clinical trials related to focal segmental glomerulosclerosis, or FSGS, and APOL1 nephropathies. So our understanding of these diseases has rapidly expanded in recent years, and these new insights have significant implications for renal pathologists, nephrologists, and kidney disease patients around the world. And the intent of this webinar series is to provide a cutting-edge update on these important topics. And I'd like to acknowledge that this series is supported by an educational grant from Vertex Pharmaceuticals, and we are very grateful for their support. So just a few quick housekeeping items before I introduce our speaker for today's session. So first of all, we've made arrangements for live language interpretation for this session into both Spanish and Mandarin Chinese. So please select the language channel that you're interested in using the button on the bottom right of your screen. And you can switch between different languages, and you can also mute the background English language channel if you so choose. So second of all, we should have time for a short question and answer session following the presentation. So please enter your questions into the Q&A section of the Zoom platform, and we will do our best to address as many of those as we can. And finally, you will be asked to complete a brief survey at the end of the webinar. So please take a minute or two to fill this out. This feedback is very important to us for planning future sessions. And in particular, given that this is the first time we're doing language interpretation, we're keen to get your feedback on how that went. So without further ado, it is my great pleasure to introduce the first speaker for our series today, who will be presenting on the pathology of FSGS. So Dr. Astrid Weins is an associate pathologist at Brigham and Women's Hospital in Boston, Massachusetts. She's an assistant professor of pathology at Harvard Medical School. She's a kidney pathologist who has been attending on the Brigham and Women's Diagnostic Renal Pathology Service since 2011. And she also directs an active translational research program studying proteinuric kidney diseases, currently funded by NephCure. In 2019, she received the Renal Pathology Society's Gloria Gallo Research Award, and also for her contributions to understanding podocyte pathobiology. And in 2019, she also received the Eleanor and Miles Shore Fellowship from Harvard Medical School. Her research focuses on understanding the pathobiology of acute nephrotic syndrome and podocyte injury by integrating morphologic observations with state-of-the-art imaging and tissue interrogation techniques. So Astrid is an excellent and engaging speaker, and I'm very much looking forward to her talk today. So without further ado, I'll hand it over to you, Astrid, and yeah, please take it away.
Thank you so much, Ben, for this very amazing introduction. I'm honored to be here today and talk to you about the pathology of FSGS. I was given this topic, and as all of you know, if you want to talk about all of FSGS, this lecture would take probably a whole day. So I'm going to limit this to some aspects of it that I think are important, and it's going to be maybe slightly unconventional the way I present on this topic. But we can discuss all of it. And what my goal is that you have at the end of this talk, hopefully a very good understanding of how to interpret FSGS in the clinical context of the patient's symptoms. So I'm going to start out with sort of a provocative slide. I want you to kind of think critically about this. Which one of these images represents focal segmental glomerulosclerosis? So when you think about what it means, focal means it occurs in some of the glomeruli of a kidney biopsy. Segmental means it occurs in the segment of the glomerulus, And glomerulosclerosis essentially means glomerular scarring. So if you look at these images, which ones do you think represent focal segmental glomerulosclerosis? So the answer is all of them. All of them represent focal segmental glomerulosclerosis as part of the Columbia classification and as part of how we use this term in everyday renal pathology. And if I tell you what they are, the upper panel here, the left one, is a so-called tip lesion variant or tip lesion in a patient with primary FSGS and nephrotic syndrome. In the middle here, you see a classic picture of primary FSGS. And here on the right, you see also an early form of segmental sclerosis in a patient with a collapsing lesion. And then on the lower panel here, this is obviously not a classic FSGS in a patient with proteinuria. This is actually a scar that results from an ANCA vasculitis. This can also look like focal segmental glomerulosclerosis, and in the classic sense, it's actually correct to name it that, but it really represents a scar. And then here in the middle, we have a patient with vascular disease and hypertrophy and adaptive perihilar glomerulosclerosis. And then we have on the right here a patient with chronic pyelonephritis and adaptive changes resulting in secondary segmental sclerosis. So now you're going to ask, well, what's the difference between all these different cases? Well, the difference is that the upper panel here, these patients all have a history of nephrotic syndrome, and the lower panel here have no history of nephrotic syndrome. So what then do they have in common that they all lead to the same kind of pathological features of segmental scarring? Well, what they have in common is they all lead to podocyte injury and loss of podocytes. So podocyte loss, and that's really going to be a key, take-home message from this talk, really is what leads to glomerulosclerosis and segmental glomerulosclerosis. So classically, we have used this kind of 2x2 panel here that delineates the causes of podocyte injury that can lead to this picture of FSGS. And we typically divide them into acquired forms of podocyte injury and genetic defects. And then these on the left here represent the ones that present with nephrotic syndrome and are characterized by diffuse and global podocyte injury. And on the right side here, you can see there are acquired and genetic causes that lead to no nephrotic syndrome in the classic sense, and focal and segmental podocyte injury, not diffuse and global podocyte injury. So as you can see, among the acquired causes, we have minimal change disease. Everyone is familiar with that. Idiopathic, or what we call primary FSGS, membranous nephropathy would fall into this category. In a broader sense, you could see podocytic infolding in glomerulopathy as well in this category. And then obviously the active phase, florid phase of collapsing glomerulonephritis or collapsing glomerulopathy. And then in terms of the genetic defects, the ones that really lead to diffuse injury, the most prominent one is congenital nephrotic syndrome of the Finnish type, which is caused by mutations in nephrin that interfere with surface localization of this protein. And then certain cases of steroid-resistant nephrotic syndrome have been reported as presenting with nephrotic syndrome, mostly steroid-resistant forms of that. Obviously, very rare conditions like Dennis-Drash syndrome, where you have genetic mutations in WT1, can lead to a very, very dramatic picture, almost presenting resembling a crescentic GN with very, very intense podocyte injury and almost looking at global collapsing lesions. And then you have patients with risk variants in APOL1 in patients with African ancestry. And then on the right here, obviously all these adaptive causes of secondary FSGS, obesity, diabetic nephropathy, vascular disease, vasculopathies with chronic progressive proteinuria and CKD. And then also what we can't forget also fall into this category are actually people from this category that have kind of moved on into the chronic phase of their disease when they no longer are in active nephrotic syndrome and just have the scarring left, and they can still have subnephrotic proteinuria, and that could encompass collapsing glomerulopathy in the inactive or quiescent phase, and also cases of primary FSGS that have progressed into a more chronic kidney disease type picture. And then also in this category fall patients with familial forms of autosomal dominant FSGS or protocyte injury. Those include Actin and 4 mutations, for example, TRPC6 mutations, and also, and this should be INF actually, Formin mutations, and then other monogenic recessive FSGS genes. And then we have obviously APOL1 risk alleles that are now in an inactive phase and no longer have the florid collapsing glomerulopathy picture, as well as basement membrane abnormalities, including all the collagen 4 mutations, and then more rare forms like MYO1E mutations, for example. So what I want to caution you though, because there can be overlaps between these things, there can be progression from one to another phase, that you can't completely rely on this. And we all tend to pigeonhole these things on the clinical side as well as on the pathology side and try to force them into one particular category. And as you hopefully will see at the end of my talk, it's not always easy to do that. And really, we have to be, as pathologists, we have to also understand the pathogenesis and etiology of these lesions so that we really truly are practicing pathology, which is not only morphology, but also the study of the causes and effects of kidney diseases. So here's, for example, one example that I can give you where you have great limitations of this pigeonholing system. This is a case that we actually had on our service. A 30-year-old African-American female presents with acute nephrotic syndrome. A kidney biopsy reveals diffuse podocyte foot process effacement, and the biopsy also shows thin basement membranes and focal collapsing features. So what are you going to do with this? You have on the light microscopy sort of a segmental pattern of early FSGS with collapsing features. You have diffuse foot process effacement, and then by measurement, you have very thin basement membranes in this patient as well. So in which category are you going to put this patient? Obviously, that's really hard because subsequently, this patient's genetic studies show a collagen defect and also 2 APOL1 high-risk alleles. So in the end, you're going to call this diffuse podocytopathy with focal segmental collapsing features in the setting of an APOL1 high-risk genotype and thin glomerular basement membranes as part of an Alport spectrum disorder. So as you can see, this patient has 3 different pictures that are not together in one single category or one single pigeonhole. And therefore, this is a difficult case that you might not be able to apply your system as you learned it. This case continues. This patient actually progressed to end-stage kidney disease within about 4 years. She received a deceased donor kidney transplant from a Caucasian donor. She presented then with massive post-transplant proteinuria 1 week after transplantation. So now you're in a position where you're questioning your previous diagnosis. You're thinking, well, maybe she did not have a genetic disease that caused this, or maybe this was not the only problem she had. Well, it turns out she has a diffuse podocytopathy. This looks exactly like minimal change disease. Essentially recapitulates her history that she had in her native kidney biopsy, the early biopsy showing diffuse foot process effacement. And then you now call this a diffuse podocytopathy that is recurrent in the allograft. And you're going to explain it by saying that there might have been an underlying basement membrane, or was, as we know, an underlying basement membrane abnormality that kind of weakens the podocyte's adhesion to the GBM. Then you have potentially a circulating factor triggered podocyte injury, which you know has to be the case because it recurred in her transplant. Then you have APOL1 high-risk alleles that interfere with podocyte survival in this patient and lead to disease progression all the way to end-stage kidney disease. And then you have a recurrence of the circulating factor triggered podocyte injury in the allograft. And in this case, we actually know what the circulating factor is because we tested her, and we will come back to that later. This patient has an anti-nephron podocytopathy, which we have described in a paper that will come out soon in JASN as a cause, an autoimmune cause of minimal change disease and also recurrent podocytopathy in the allograft. So this is why pigeonholing is problematic in FSGS. You know, you have here minimal change disease, FSGS, and collapsing glomerulopathy, kind of sitting on a spectrum of podocyte injury. And the reasons why this is problematic, you can see actually different patterns in the same patient. So in a patient with FSGS, you have completely normal glomeruli that look like minimal change disease, really. And in a patient with FSGS, you can also have more severe podocyte injury in other glomeruli that look like collapsing glomerulopathy. You can also see disease progression from one pattern to another. So we've seen this several times, that especially patients presenting with childhood minimal change disease who are therapy resistant and progress to develop FSGS. And some patients might also go from minimal change disease and progress to collapsing glomerulopathy. So you see disease progression from one pattern to another, so it doesn't necessarily fit one particular category at every stage of disease. Just remember that a biopsy is one time point in this patient's disease and not necessarily represents the full spectrum of what you will see and have seen in this patient. And also, you can see a combination of etiologies in the same patient. As I've just shown you in this patient, there were genetic causes, two different genetic causes, and there was an acquired cause that was superimposed on the genetic causes. So it's important to establish predisposing factors. It's important to establish disease initiation factors, and it's important to establish disease progression factors in patients with FSGS. So when I've sort of decided to now focus mostly on primary FSGS because it's just not possible to discuss every single entity that leads to FSGS in the kidney. So when we want to learn about primary FSGS, we need to understand two different processes. We need to understand how the nephrotic syndrome in these patients actually develops. And then we need to understand how it injures the podocytes and how podocytes are lost in these patients. So that's what I'm going to talk about in the next few slides. So in this category of primary FSGS, or primary podocytopathies, we include these three conditions, or I include those. Other people might have different views on what goes into this category, but I include minimal change disease, which typically, or as we know, has no genetic abnormalities underlying this condition, although there might be some that we just don't know yet. And we know that it must have some kind of acquired trigger. Then the primary FSGS category might have or not have possible underlying Mendelian variants in FSGS genes, and then superimposed on this potentially also has an acquired trigger that will then progress these patients not to just minimal change disease, which they all have in the beginning because you can't start out with scarring. They will actually progress away from the minimal change disease pattern to a scarring pattern because they have more podocyte loss. And then there's also the collapsing glomerulopathy, which is often seen in patients, not always, but often in patients of African ancestry with APOL1 high-risk genotypes. And then often also an acquired trigger of some sort that will actually initiate the podocyte injury that will then result in the collapsing glomerulopathy. So what do they have in common? In common, they all have basically ultrastructural features, which include diffuse podocyte foot process effacement, as you can see here on the left. Also, loss of slit diaphragms, which is interesting. You know, we don't really pay that much attention to this. When we look at the EM, we always just say, oh, there's diffuse foot process defacement. But what really is interesting that, especially in minimal change disease and primary FSGS, you see you see a diffuse loss of slit diaphragms and these gaps between adjacent podocytes. And this is an image I took years ago. It's basically just an actin staining of a patient with minimal change disease that shows you that along with the foot process retraction, you always get a kind of a clefting between podocytes where the podocytes move apart and leave these clefts, these open spaces where typically you would see the slit diaphragm. Then obviously the absence of immune complex deposits and the presence of nephrotic syndrome are also common features in these cases. How do we know that the podocyte is really the target in primary podocytopathies? Well, there's most of all, and most importantly, from the past, there's a huge amount of papers, huge number of papers as early as, you know, the early 1900s through the 1950s and 60s to now, where we have a massive amount of historical data on podocyte injury and nephrotic syndrome. We know that there must be a circulating permeability factor involved. So this is no longer just a hypothesis. I think the presence of lesions that are very similar to minimal change disease in patients that progress and then represent again in the allograft really nails down the hypothesis that this has to be a circulating factor in these patients. We know there's disease progression and can be from minimal change disease to FSGS to end-stage kidney disease and then later to recurrent FSGS, as we call it, or recurrent podocytopathy in the allograft. We have made a lot of discoveries along the lines of genetic podocytopathies that show similar pictures where we learned about the importance of certain proteins and learned about the molecular structure of the podocyte. And we also understand a lot about the pathophysiology of nephrotic syndrome. So let's go through some of these things. In the old days, before electron microscopy was used to diagnose this entity, we called these diseases lipoid nephrosis based on the presentation with, you know, lipoid casts in tubules. And so this is the first edition of Heptonstall's Pathology of the Kidney, which came out in 1966. And this was really the first book that showed that this is not a tubular disease. It was actually a glomerular epithelial disease. And this was in part or mostly really due to the discovery of Marilyn Farquhar, where she used electron microscopy for the first time to diagnose and really examine the ultrastructural features of nephrotic syndrome biopsies. And then also we know that these cases can progress to primary FSGS, which was first described by Farr in the late 1950s, that you can see progressive sclerosis of the glomeruli starting in the juxtamedullary region of the kidney, as was initially described by Rich. And that appears to be the usual way in which these cases of lipoid nephrosis, or as they were later called glomerular epithelial disease, will progress. And again, as I said, even back then, they were very cognitive of the fact that these terms really just present the state of the affairs in the kidney at the time of that biopsy. So we don't know where the disease started, and we don't necessarily know where it's going. So we can only regard them as stopgap titles. And when we know more about the natural history of these conditions, then maybe we can consider some new names. So, well, we haven't really given them much new names. We still call it minimal change disease. We still call it primary FSGS, as it was called in the 1950s. So really, I think we're on the verge of maybe understanding a little bit more about these things. About the circulating factor, what do we know about that? So the first really interesting findings were made in 1954 when people were performing ethically very questionable experiments of administering plasma from nephrotic infants to healthy infants who then developed transient proteinuria. So the factor has got to be in plasma from these nephrotic infants that were given to the healthy infants. In the 1980s, there were also some experiments done where FSGS patients, sera from FSGS patients was infused into rats, which then rapidly developed proteinuria. So again, evidence for a circulating factor present in this serum. There are also cases that were published in the 1990s of maternal fetal transmission of proteinuria in mothers with nephrotic syndrome that then went away in the infant. And then in the 1990s, with the advent of plasmapheresis, obviously that was shown to transiently, at least, and in some patients permanently decrease proteinuria and leads to partial or full remission of nephrotic syndrome in some of them. So again, something was removed from the plasma, from the blood in these patients by the process of plasmapheresis. And then finally, in the 2000s, and the latest case report was just published this year, there is a known disappearance of proteinuria when you take a transplant kidney from an FSGS patient who recurred before, take the kidney out of this patient and retransplant the kidney into a recipient that has no known history of nephrotic syndrome. And this patient, you will initially still see some proteinuria, but that proteinuria goes away relatively quickly. So really that means that the factor is circulating in the former recipient with a history of FSGS and nephrotic syndrome, but not in the recipient, the second recipient with another cause of his kidney disease. And then over the years, we've had a lot of different proposed candidates for permeability factor, and I'm not going to go in great detail on all of those, but I can basically tell you that none of those really fulfills all of Koch's postulates as a circulating factor, a disease-causing factor that will lead to this disease. And all of them have been either debunked or have been, sort of reinterpreted in a different context. And so I think none of those is really truly the permeability factor that we're all looking for. Then there's some recognition that certain cases of minimal change disease, primary FSGS and recurrent FSGS in the allograft must share a common cause. And, the first recognition of this was actually published in 1972 by John Hoyer. And this is a milestone paper that was again featured in the early 2000s in the Journal of the American Society of Nephrologists. This was originally published in The Lancet. This was 3 case reports of patients with recurrence of idiopathic nephrotic syndrome after renal transplantation. And we can see that renal biopsies from these patients showed typical features of idiopathic nephrotic syndrome with no or minimal focal glomerular abnormalities. So really, they all had minimal change disease to begin with, but they all progressed to renal failure within several years, and they all 3 recurred in the transplant with a picture very similar to what they initially had. And then you could actually follow them after their kidney transplant. First, they had a minimal change disease-like picture, and later they showed focal segmental glomerular sclerosis, which was limited to the juxtamedullary glomeruli. Essentially, they were recapitulating the injury they had in their native kidney again in their transplant kidney. So, this was discussed by by some very prominent nephrologists in 2001. I think it was Shankland and Bill Smoyer that were discussing this, and they already recognized that this is a very important insight into the pathogenesis of minimal change disease and FSGS, which we maybe somehow have forgotten about a little bit by now trying to force them into one or the other category. This is actually really a nice report, and the three takeaway points from this is that minimal change disease can indeed progress to FSGS and recur as recurrent FSGS, recurrent podocytopathy, that then progresses again to FSGS if not adequately treated. Also, it shows that minimal change disease FSGS and recurrent FSGS show very similar ultrastructural morphologic features. So if you showed me a case of recurrent FSGS in the allograft, I would not be able to tell you, if I didn't know that was an allograft, that this isn't a patient with minimal change disease. And then we also then understand that they are all likely caused by a common circulating permeability factor. And then there's more evidence for this. This is a very interesting manuscript that I invite you to read by Rutger Maas from the Netherlands and certain other European pathologists and also nephrologists in Nature Perspectives, where they kind of postulated the theory or hypothesis that really the intensity of podocyte injury will define whatever lesion you will present with in your biopsy. So if you have, not such intense injury, you may end up having minimal change disease. A little bit more intense injury that is more sustained might lead to a tip lesion variant, and then later on progress to potentially an FSGS NOS type picture. And then when you have very rapid and intense podocyte injury, where in a short amount of time, a lot of podocytes will die or detach from the basement membrane, you'll end up with a collapsing variant type picture. So really, it's kind of a continuum, if you look at this, from minimal change disease over FSGS, over maybe cellular variant collapsing lesions, to all the way to, which is something that can be seen in a WT1 mutation, where you have absolutely no viable podocytes left, and you have these almost crescentic lesions in these kids. So really, you have a loss of podocytes, and at the same time, you get a PAC, a parietal epithelial cell reaction to the injury, which you see in collapsing glomerulopathy. Those are all parietal epithelial cells. I think that has been now proven on a lot of different levels, and that will be more intense the more podocyte you lose. And then this kind of, if you look at this, this reminds you of the Columbia classification, which is how we classically were trained to classify these lesions as collapsing variant, tip variant, perihilar variant, cellular variant, and not otherwise specified NOS variant, which probably most of FSGS falls into. But really, you have to take these with a grain of salt. You can use that classification. It's useful to understand the lesion, but not all of these are really defining a particular disease entity. You can see NOS lesions in most of any type of podocyte injury, if it's primary, idiopathic, or secondary, genetic or acquired. So it doesn't tell you anything about what caused this injury if you don't take it into the appropriate clinical context. So let's talk about the podocyte. Since the podocyte is at the center of all these presentations of primary podocytopathies. Podocytes line the outer aspect of the GBM. This is a picture of one. This is the cell body. You have this first primary processes, secondary processes, and then the tertiary or foot processes, which interdigitate with each other in this very organized manner. And in between them, you have the podocyte slit diaphragm running. As we know, podocyte injury with foot process effacement and loss of the slit diaphragms is typically associated with albuminuria. And we also know that podocytes are highly differentiated cells with very limited to no capability to really undergo cell division in the adult. So essentially, when you lose a podocyte, that podocyte will be gone forever and it will not be replaced by another podocyte. And what we also know is that a loss of podocytes is a hallmark of glomerular disease progression, as was shown by Roger Wiggins, and I will come back to that. What we also know is we've made a lot of discoveries in the past 20 to 30 years about genetic causes of podocyte injury, and thereby we've learned about the structure and organization of the podocyte foot process in a very, very intricate and very, very detailed way. So we know that there are slit diaphragm components here that, when mutated, will lead to very severe, potentially, forms of podocyte injury with loss of slit diaphragms and diffuse podocyte foot process effacement, and also nephrotic syndrome. There are mutations in actin cytoskeletal components. The actin cytoskeleton of a podocyte is extremely highly organized into these long bundles of actin that run along the center of the podocyte foot process. And these are cross-linked by very highly specialized actin cross-linking proteins, such as synaptopodin and alpha-actinin 4 and formins, and are connected to both focal adhesions and also to the slit diaphragm. So you can imagine then that every alteration in slit diaphragm composition will also have an effect on the actin cytoskeleton and will lead to actin cytoskeleton breakdown and potentially foot process effacement and actin signaling. And then also any kind of alteration of the cell matrix interaction, most notably by integrins and through components of the glomerular basement membrane, will also have an effect on the actin cytoskeleton as well as on the slit diaphragm composition and signaling. So this is an incredibly well organized, intricate system in a podocyte foot process in which any kind of perturbance or perturbation really leads to differences in all the other components that will produce some kind of abnormality, structural abnormality that results in proteinuria. So how do we put this all together to explain the development of acute nephrotic syndrome? And this is a beautiful sketch, schematic that you can find in this book down here, written by Helmut Reinke and Brad Denker. So what we know is that the consequence of these podocyte alterations that we see in acute nephrotic syndrome, mainly podocyte foot process effacement and loss of slit diaphragms, lead to massive albuminuria, which is secondary to failure of the glomerular filtration barrier with loss of the specialized junctional slit diaphragm complex. So putting this together and explaining this, under normal circumstances, here seen on the left, you have an intact small pore system of glomerular ultrafiltration where you have a very organized filtration process through small pores, okay, through the three layers of the endothelium with the fenestrae, the glomerular basement membrane, and the interdigitating specialized junctional slit diaphragm complexes that has quite a bit of resistance to flow. And that'll allow for a very effective reflection of these positively charged molecules like albumin by the negative surface charge of the endothelium. And you will have no significant albuminuria under normal circumstances. However, when you have both the foot process effacement and the loss of the slit diaphragms in this diffuse manner, you will lose filtration surface. You will have large defects in coverage of podocytes in between the podocytes that are larger than your usual small pore system. And you will have more resistance in areas where you have foot process effacement, where the podocyte is lying directly, broadly on the glomerular basement membrane. This leads to an increase in hydraulic conductivity and then an ineffective reflection of these positively charged molecules by the negative charge of the endothelium. So if you take away the most distal layer of the system, the proximal layer doesn't work any longer. And thus you result in acute nephrotic syndrome in these patients. And so we've basically taken this and have thought critically about how would you lose the slit diaphragm? What would be a process that you could have that's acquired that would result in a loss of slit diaphragm complexes acutely and very quickly? And the only thing we could come up with is really it has to be potentially an autoantibody that's directed directly against one of the slit diaphragm components. And the most prominent candidate for this is nephrin. And so indeed, and I'm not going to go in great detail because we're talking about FSGS and not about acute nephrotic syndrome only, what we discovered is that autoantibodies targeting nephrin are present in about 30%, at least 30%, I should say, of patients with minimal change disease. And they're present in active disease, they're absent in disease remission, and you can find them also in the biopsy in the form of very fine granular punctate IgG staining, which I'm sure most of you in your particular institutions, if you have really good IF and good magnification on your microscopes, you can see this punctate IgG, very sparse, very diffuse, but very subtle staining in your minimal change disease cases. We've seen it, we see this typically in about 60 to 70% of our cases of minimal change disease. And therefore, I think that this 29% we discovered in this Neptune cohort actually represents an underrepresentation of how many patients truly have circulating nephrin autoantibodies. And as you can see here, we also found that these antibodies are present in the biopsy and co-localized with nephrin, but not with other podocyte markers. And we have these circulating nephrin autoantibodies in all cases that were IgG positive, but in no cases that were IgG negative in the biopsy. So a beautiful study done by my postdoc, Andy Watts, and my lab manager, Keith Keller. And it's going to be published very soon. It's accepted. So I want to show you now a case, which I haven't published yet. It's actually a 69-year-old Caucasian man. He has a history of type 2 diabetes. He presents with acute kidney injury, a creatinine of 3.5. He has anasarca, he has hyperlipidemia, he has low serum albumin, and he has 18 grams of proteinuria when he was seen. So classic acute nephrotic syndrome in a Caucasian man. Serologies were all negative, including anti-PLA2R, phospholipase A2 receptor, which you can see as a cause of membranous nephropathy. His free light chain ratio was slightly elevated, but not enough to think that this might be amyloid. So a kidney biopsy was ordered, and the differential diagnosis included minimal change disease, membranous nephropathy, primary FSGS, and then paraprotein-related diseases, which were these three last entities are more unlikely. Anyway, so here's the clinical course of this patient. You can see the low serum albumin. You can see his UPCR, his urine protein over creatinine ratio, very high. Here's when the biopsy was performed. And then we collected 3 serum samples at these plasma samples at these 3 time points early on in the course of the disease, 1 before steroid therapy was initiated and 2 after. As you can see, the histopathological workup in this patient showed diffuse podocyte foot process effacement and also showed some of that clefting of the podocytes where they move apart and don't have the typical slit diaphragm in between them. And then, but also there was perihilar, if you want, mild perihilar segmental sclerosis, and there was also features of collapsing glomerulopathy in this patient. So this was not just minimal change disease, even though the clinical course really looked or sounded like this might be it. And then, as you can see here, the findings by IF were mostly negative, with the exception of IgG, which I will show you in a second. So this was called the diffuse podocytopathy with early features of focal and segmental glomerular sclerosis. and also kind of a focal segmental collapsing lesion here. So looking at the IF, we see that there is this fine granular IgG staining, together with some also very coarse protein reabsorption granules, which we often see, especially when we have collapsing lesions. And these reabsorption granules stain nicely positive with albumin as well, whereas this fine granular staining does not stain positive for albumin. And if we do the confocal microscopy for IgG and nephrin, they co-localize in this granular staining, essentially demonstrating that this patient must have an IgG that recognizes or binds to nephrin. And indeed, when we looked at these 3 plasma samples we collected from this patient compared to a patient with minimal change disease that was a known positive, all 3 plasma samples were positive for anti-nephron antibodies. So now we know there is a patient with early primary FSGS that has anti-nephron antibodies. So there's a common etiology in a subset of FSGS that is in common with minimal change disease. So this is the disease initiating factor. But now the question is, why does this patient have these segmental collapsing lesions? He obviously is Caucasian, so he probably doesn't have APOL1 risk alleles. He doesn't have thin basement membranes. He doesn't have any other known features. He does have diabetes, which might represent a sort of pre-stress to his podocytes already. And that's why he has these lesions that typically in minimal change disease do not occur. So again, this kind of, begs the question, do we need to look at the disease initiating factor? And do we also need to look at other factors that make one patient progress to FSGS and the other patient not? So again, going back to podocyte loss, this is from a paper from Yvette Dagati, which was published in 2008. She had a very insightful, take on this back then and still to this day. There are a lot of animal models that have shown that sustained podocyte injury that leads to podocyte loss eventually results in segmental or global glomerulosclerosis, and that sometimes you might take a second hit really to exacerbate the injury to a point where you have irreversible podocyte stress, and then the podocytes will detach or die, leading to glomerulosclerosis in either a segmental or in a global pattern of glomerulosclerosis. And we know this from models of toxic podocyte depletion, which was performed by Roger Wiggins using diphtheria toxin, where he depleted different numbers of podocytes and could show that the more podocytes he depleted, the more likely it was for these animals to progress to segmental or global glomerulosclerosis. We have shown similar things in a model using adriamycin, where we injected adriamycin at different dosages into mice and showed that low-dose adriamycin injection leads more to minimal change disease-like pattern, and a lot of the mice kind of recover from that. And the more you give, the more segmental sclerosis you get, and even if you give a lot, you get collapsing glomerulopathy like features in these animals. And then Wilhelm Kritz from Germany had beautiful morphologic studies in a uninephrectomy model in rats, where he also showed that if he tied off one of the renal arteries and had essentially a uninephrectomy, the other kidney would have more stress and would hypertrophy, and then eventually would get podocyte detachment or podocyte death in these animals. And then beautiful studies using the CD25 LMB2 model by Ichikawa that also demonstrated this kind of dose-dependent podocyte loss that leads to glomerulosclerosis. Here again, these are the studies by Roger Wiggins. This is the paper. You can see the more podocyte loss you have, the more likely you are to progress to sclerosis. And here are these beautiful studies, morphologic studies by Wilhelm Kritz and Kevin Lemley, a paper that I highly recommend you take a look at, because it's just beautiful ultrastructural morphology showing podocyte death and also showing podocyte detachment from the basement membrane, and then later on leading to glomerulosclerosis. And these are just some studies I played around with several years ago, where we took a case of a patient with a segmental collapsing lesion and stained them for a podocyte marker. This is synaptopodin here in a normal kidney, and compared to a segmental collapse, where in the area of collapse you have complete loss of synaptopodin staining, and that gets replaced. Those podocytes are replaced by parietal epithelial cells expressing a parietal epithelial cell marker, PAX2. And the same is also true in this lesion here, which is basically segmental sclerosis, where you have, PAX2 positive parietal cells that will move over to the tuft, but you have a loss of podocytes here. We use WT1 as a marker in that particular area. So clearly, podocyte loss seems to be one of the factors that clearly leads to segmental sclerosis. And then is there actually, are there features of podocyte death that you can see in humans with primary FSGS? And this is a case that is a very beautiful demonstration where you can see here a segmental sclerotic lesion, and here's another one. So you would classify this as NOS, not otherwise specified, because it's not only a tip lesion, it has another focus here. This is a patient with primary FSGS who had acute nephrotic syndrome. And as you can see, there are features of cell death that are present in these lesions, indicating that these might represent dying podocytes or dead podocytes. And now you see this capping by parietal epithelial cells in this kind of adhesion that is formed in these two foci. And again, you can see in this patient, there's diffuse podocyte foot process effacement. And then there's also detachment of podocytes from the basement membrane, away from the basement membrane. And this is from a human case. So again, you see these features in patients that were described in animal models of disease. So really, there are different pathways how you can lose a nephron or lose part of a glomerulus due to obsolescence or glomerulosclerosis. If you lose just a few, if you have a case of podocyte hypertrophy, or if you lose just a few podocytes, the other ones will hypertrophy. And then you will lose some of them potentially, and that will lead to FSGS. Whereas if you have a lot of them that are lost at the same time due to a genetic vulnerability plus an outside trigger that really causes very intense podocyte stress and sustained injury, you will lose them rapidly, and that will lead to a collapsing lesion, or a segmental or global collapsing lesion. So the take-home messages from this talk really are that you should remember always that FSGS is a pattern of glomerular injury. It's not a disease entity, okay? You can see it with all kinds of podocyte stressors that may lead to that may go to the point of killing or stressing the podocytes to a point where they detach and they're no longer present on the tuft. I also want to caution you against just completely relying on these classifications, may they be clinical or morphological. And those classifications are only useful or most useful when you put them in the appropriate clinical and pathophysiological context. So you should never blind pigeonhole your cases and say, well, this has perihilar glomerulosclerosis, so it must be vascular cause, or this is a tip lesion, so this patient has primary FSGS. Even though they are most common in these patients, they can appear in other clinical contexts. The other take-home message is that there is a cause for non-congenital acute nephrotic syndrome, which is caused by an autoimmune mediated process, at least in a subset of those cases, and it presents with diffuse podocyte injury. I also want you to understand that disease progression to glomerulosclerosis in acute nephrotic syndrome, and that's segmental or global glomerulosclerosis, is always a result of podocyte loss. And that could be due to sustained podocyte injury or underlying podocyte vulnerabilities. And they can be genetic, APOL1, podocin mutations, Actin and 4 mutations, or other things that we don't even know exist yet because we've never looked at this in this context of a genetic abnormality that requires a second trigger in order to present. Environmental stresses, obviously, metabolic stresses, diabetes, vascular diseases, very important. If you have pre-stress in podocytes and already have lost a number of podocytes due to that before, when you then get a trigger, an acute trigger like an autoimmune mediated anti-nephron podocytopathy, you're much more likely, in my view, to progress to a segmental or global glomerulosclerosis. And then the last thing that I think is important, that the specific features of permanent glomerular injury and following this podocyte injury depends on the intensity of the injury, the sustained injury or short-term injury, the length of the injury, the intensity of the injury, and on the number of podocytes lost. So if you lose a lot of them at the same time, you result in more of a collapsing type picture. If you lose just a few, you may just have some hypertrophy and eventually have a secondary glomerulosclerosis, similar to what you see in adaptive changes or adaptive FSGS. So with that, I'll end. And I just want to acknowledge my lab members, Andy Watts and Keith Keller, here on the left. And then obviously Dr. Renke, who's been an amazing teacher and has really taught me that you can never just rely on any kind of morphologic data. You always need clinical history. You need to put it all into pathophysiological context. And that's really what is important in renal pathology, and especially in the interpretation of FSGS. And then there are a lot of other people on this slide that I owe my thanks to with regard to the anti-nephron story. And stay tuned for the peer-reviewed paper that should come out very soon that will hopefully clarify some of the causes of acute nephrotic syndrome. Thank you so much.
Right. Thank you very much, Astrid, for this excellent update on what is obviously a very rapidly expanding and evolving field. I think there's still obviously a lot to be learned about this category of diseases, but thanks to the efforts of your team and others, I'm confident that we will be able to further improve our understanding of their pathology and pathophysiology, and eventually improve our ability to provide excellent patient care. So yeah, we do have several questions both in the QA and the chat. I'll maybe start with the QA. I don't think we obviously won't be able to get through all of them before the hour is up. If you're able to hang on for a few extra minutes, we'll maybe try to get through as many as we can. But yeah, I'll just start at the top here. Parmjeet Randawa has a few questions. First one is regarding primary versus secondary FSGS. Do you only assess the extent of foot process fusion, or do you include areas with microvillus transformation in the % area of capillary loops affected by podocyte injury?
Yeah, so I don't really use the percentage at all. To me, it's diffuse versus not diffuse. And, I kind of lump together very extensive and diffuse cases with, focal or segmental foot process effacement. And it's important to also see this in the context of clinical history. I would never just rely on that one feature to help me in my diagnosis. And if I'm not sure, I'm going to say that. I'm going to say this is a case where, due to lack of clinical history or unclear presentation, I cannot make the diagnosis of one versus the other. And they have to put it on the clinical side into a context. But, you can have a partially treated minimal change disease that already has no longer diffuse foot process effacement and is still minimal change disease. So these things are important to remember, and you can't always force something into a category. And so I don't really, use a percentage of foot process effacement in my reports.
Okay, Thank you. A couple more practical questions from Parmjeet. Can foot process fusion occur in severe ischemic injury? This question crops up in early post-transplant biopsies with delayed graft function and nephrotic syndrome. Often it is not even known if the cause of transplantation was FSGS or not.
Absolutely. I think you can see that, and you should keep that in mind, that if you have severe ischemia and delayed graft function, you can have diffuse foot process effacement, but you usually don't have full nephrotic syndrome in these patients. And that's something to remember, because you won't lose all the slit diaphragms at the same time. So remember that I said you need to have foot process effacement. By the way, it's not fusion, because they don't fuse, they retract, and then they just lose connection. But I think that one should always have that in mind, that you can see diffuse foot process changes in a transplant kidney with delayed graft function and ischemia, but never with full nephrotic syndrome.
Yeah, I agree. Last question from Parmjeet. You have many elegant papers on immunohistochemical staining of podocytes. Do any stains differentiate between florid podocyte hypertrophy and crescent formation?
I'm actually just thinking about that, because that's a very common problem we have, that we can't differentiate between a collapsing lesion and a crescent. In some cases it can be quite difficult sometimes, and I think that the presence of inflammatory cells might be one thing, the presence of fibrin might be another thing, but real markers, you would need to employ parietal epithelial cell markers in order to really show that it's a collapsing lesion that's really just composed of parietal epithelial cells, because that's what a collapsing lesion is. You won't find macrophages or any kind of other inflammatory cells or fibrin in there. So, those are things that we have to think about a little bit, and maybe that could result in a helpful tool for renal pathologists.
Okay, I've got a question here from Banu Sis. How do you explain the lack of electron-dense deposits on EM in those with anti-Nephron autoantibodies and minimal change disease FSGS? Maybe you need more time and follow-up to deposit the immune complexes?
No, I think that what happens is that these are shed at some point. So they likely remain on the surface or get endocytosed and then shed. And you will not see immune complexes. Remember, immune complexes are massive amounts of antibody antigen complexes that are formed over the course of several weeks, most commonly in membranous nephropathy. We don't see that in anti-nephron podocytopathy, and they go away. After a while, you don't see this staining anymore. And we've seen cases that are more, advanced, where therapy was delayed, where that staining disappears, because remember, if you don't have nephron anymore, then you don't have anything the antibody can bind to. So what you see as this granular staining is probably still surface localization or membrane-associated, lipid raft-associated IgG and nephron, and that these complexes are being shed pretty quickly, and that's something very typically seen in these surface antibodies.
Okay, thanks. Here's a question from Geetika Singh. Do you think that the term minimal change disease needs to be reconsidered?
I don't use it. Yes, I do. I think we should call it diffuse podocytopathy with minimal changes by light microscopy if you want to, but really we should call it by the cause. And if we know the cause, we should say it's probably anti-nephron mediated, just like we use anti-PLA2R mediated membranous nephropathy.
Okay, yeah, cool. Question from Marwa Abdullah Al-Riyami. This is a tricky one. How do you distinguish between diabetic Gn with primary collapsing FSGS versus diabetic Gn with collapsing glomerulopathy due to ischemic changes? If that makes sense. I don't know if it's possible.
Well, you can't. I think you need to know. So in a patient with, that's why we need to understand these etiologies, right? That's why it will be important to include the measurement of anti-nephron antibodies into a panel at some point, just like we now do with anti-PLA2R antibodies. We need to figure out how we can learn about the etiology in order to really understand what's happening in the patient. If the patient's not nephrotic, usually patients with secondary collapsing lesions due to just, ischemia or advanced diabetes do not have full nephrotic syndrome. They might have nephrotic proteinuria, but they usually don't have full nephrotic syndrome. And so I think, you always have to kind of put it all together with the clinical context, and then you might be able to, get to a conclusion. But, ultimately what we need to understand is why do some people get this? Why do other people not get this? And then I think these anti-nephron antibodies might help us in identifying those patients with diabetes that have a superimposed trigger acquired podocytopathy that leads to their problems.
Yeah, I completely agree. Another practical question here: in cases where you don't have clinical history, but you see diffuse podocyte injury on pathology, what diagnosis would you suggest making in those cases?
Well, you can always call it a diffuse podocytopathy, right? I mean, if you see the feature of that IgG dusting on the IF, which, I already feel very confident that it's minimal change disease or minimal change or something along the lines of a diffuse podocytopathy caused by anti-nephron antibodies when I see this kind of fine granular dusting. I don't even need to see the EM. It always ends up being minimal change disease or early primary FSGS with tip lesions or even like more advanced stages of that. But I think that, it's hard to do anything in renal pathology without clinical history. So if you get a case without clinical history, do everything you can to get the clinical history.
Yeah, that's what makes renal pathology so fun, I think.
Yeah.
Is that opportunity to integrate all the different information sources. Okay, another question. The response to steroid therapy is obviously quite different between minimal change disease and FSGS. How do you interpret that with the same mechanism and just different patterns?
Well, I mean, it depends. There might be different reasons for that. One reason is you've already moved on to the next phase of the disease. You're no longer in the active autoimmune disease production of antibodies phase, but you've moved on to developing podocyte injury and have podocyte loss and have residual proteinuria due to that. Some patients may not respond because you're too late in the course of the disease. You will no longer have the ability to suppress antibody production enough and fast enough so that you have antibody production down and give the antigen, in that case, nephron, the ability to recover. And then you might have patients that have genetic abnormalities in nephron trafficking that may make it impossible for these patients to reform their slit diaphragms after they've been destroyed, So that might be another cause, and there might be genetic mutations. I think some of the podocin mutations have already been shown to be affecting nephron trafficking. So it will be very interesting to see if these patients initially maybe have anti-nephron podocytopathy, and then they have, due to their inability to re-traffic new nephron back to the slit diaphragm, they can never reform their slit diaphragms. And so they will remain nephrotic even under therapy. So there are all these different theories that I have in my head that might be at play. And I think we need to just kind of look at that prospectively and see what we find.
Okay, thank you. We still have a couple questions in the Q&A and several questions about your work in the chat. Are you okay to keep going for a few minutes?
Sure.
Okay. All right, so I guess a follow-up treatment-related question from Kelly Smith. Are you aware of any correlation between anti-nephron podocytopathy and response to rituximab or other B-cell targeting therapies?
Yeah. So I can't give you a definitive answer because that requires a prospective study. But what I can tell you is that several patients with anti-nephron podocytopathy in our institution were treated with rituximab successfully, and it makes sense because rituximab would, suppress the antibody production by B cells. What it doesn't do is once it gets to the plasma cell level, it may not help as much then because plasma cells are not affected by rituximab therapy. So you just kind of have to time it right. I think that's very important. But I think it's been shown that rituximab can be very effective for patients with especially treatment-resistant nephrotic syndrome, steroid-resistant or steroid-dependent nephrotic syndrome, I should say. Those are the ones that are usually responding well to rituximab.
Okay, an observation by one of our participants that cellular and collapsing often overlap.
Yeah.
How often do you diagnose true cellular variant is the question.
I never give it a variant. I mean, if I see something like a cellular variant where you have these, abundant parietal epithelial cells on top, that to me is a feature of collapsing glomerulopathy. And so, to me, this is all a spectrum, as I showed you. So it really isn't important if you call it cellular variant or collapsing. The only thing that it might trigger some different workup in these patients, obviously, but I think in my mind, this is a continuous spectrum. And a patient with a segmental collapsing lesion and a patient with a cellular variant, these two lesions might exist in the same patient even. So I think, it's very hard to kind of draw the line. And that's why I'm saying this is where these categorizations and classifications fail us, because we cannot, force every case into a specific category.
Mm-hmm. Yeah. Okay, so there is obviously a lot of excitement and gratitude for your work and giving the talk today, expressed in the chat. Several questions about your work in particular. I don't think we'll be able to get through all of them, but we'll maybe chip away at a few at least. So you can see these here. So Matt Palmer is asking, what proportion of patients with minimal change disease or FSGS do you think have anti-nephron?
How many? I think a lot. More than 50%, I would guess. Maybe even close to 80–90%, based on what we see on the biopsies with minimal change disease. And then FSGS will be more tricky to establish, because often we see them much later in their presentation. They may no longer have the active autoimmune disease at that point. So who knows what happened before? So that'll be always hard. So I think prospective studies are going to be the only way to determine that. And also how much genetic workup we should be doing in these patients with FSGS, because for all I know, every patient with FSGS could have some kind of genetic predisposition. So I think ultimately, the more advanced our technologies become, it might be interesting to see, as part of an organized study, how many patients do have any kind of, polymorphism in nephron or other molecules that might play into this picture, into the clinical picture for these patients.
Okay, Kai Hong Zheng has asked, can nephron and anti-nephron antibody form immune complexes like in membranous nephropathy?
No, and that's really not something we would expect, because remember, the immune complexes you see in membranous are being shed down underneath the podocyte. So they have nowhere to go, but they have to accumulate there because, they're basically being shed into the basement membrane. There's nowhere to go for them. Whereas nephron is at a position where you have continuous flow, and so they will be taken up by the podocyte. And you've seen that in other cases, like pemphigus, for example, where you have antibodies against desmogleins. Same thing happens there. The antibody complex forms, the thing gets taken up into the keratinocyte and then is degraded or shed. And so the same thing will happen in the podocyte. You will not have immune complex formation as we see in immune complex associated podocytopathies, such as membranous nephropathy. And I think that's very important that we remember that not every antibody in the kidney causes an immune complex deposition disease. That's obviously not true. We have a lot of antibodies that cause functional interference with their antigen, and other diseases like myasthenia gravis, Graves' disease. All these things are functional antibodies and not the immune complex deposition diseases. And the same is true in the kidney.
Okay, so we're at almost 15 minutes past the hour, so I think I'll just go ask this one last question, and then I'm afraid we'll have to forward the rest to you to maybe reach out to the questioners directly. So Carmen Avila Casada has asked, the anti-nephron animal studies, or commented the anti-nephron animal studies in the 80s failed to produce diffuse foot process effacement or nephrotic proteinuria. Do you have any idea why this may have happened?
I don't know. Maybe because it's a dose effect. Maybe they were directed against a different epitope of nephrin. I don't know. But what we do know is that all these animals had massive proteinuria, actually. And so I think that we can learn a lot from these animal studies, that they had similar features to what we see in patients with minimal change disease, even though there might not be complete overlap. And also they're mice. They're rodents and not, actually rats and mice and not humans. So there might be differences from mouse strain to mouse strain and, from mice to humans.
Great, thanks so much. Yeah, so I apologize that I wasn't able to get through everyone's questions. There's obviously a huge amount of interest in the topic and in you as a speaker, Astrid. This is the most participants we've ever had for an RPS webinar by far. So
oh, wow.
Congratulations on that. Yeah, so thanks again for the fabulous update. Yeah, congratulations on your own work coming out of your group. Yeah, and yeah, we're very pleased that we were able to have you here today. So just a brief announcement, our next lecture in this webinar series will be Dr. Jeffrey Kopp, providing an update on APOL1 nephropathies on November 18th at 11 a.m. Eastern Time. So same time in 3 weeks. So thanks everyone for participating. Thanks again to Dr. Weins for the great talk, and we'll see you in a few weeks.
Thank you for having me. This was fun.